So let's get started now. Some of you may have attended here before, attended one of these sessions before. If so, again, you know the drill here. We want to make sure we have a good connection, that you can hear me loud and clear, and that you don't have any interruptions. So anything that chews up bandwidth, put that on hold or pause or turn off, like if there's TV or Netflix or something streaming in the background, and you've got a dodgy connection. I'd suggest turning that off. If you need to, you can reconnect. That's absolutely fine if you are having troubles. But everything's been going fairly smoothly so far. Our mission with Migraine Headache Australia is threefold. We're going to be talking about research that's front and center here in front of us. That's a big part of what we do. We also aim to provide trustworthy and reliable information with medically reviewed articles on our website. And we also advocate and support people living with migraine and headache disease as well. And each night we've been talking about one of these sort of pillars of work that we've been involved in this year. And so tonight we're going to be talking about government advocacy. Now, I know there's a lot on this slide because there's been a lot happening, actually. And since 2019, we've increased our presence and have been building a coalition of support on both sides of Parliament. And if you're familiar with the government, and if you've done any government or policy work or advocacy or lobbying, you know that the pace is slow and gradual, but it requires consistency and showing up time and time again. And there's a lot of issues that we're working on. And at the top of that list at the moment is keeping women in the workforce with migraine. We know that migraine disproportionately affects middle-aged women, up to 1 in 4 middle-aged women. We'd like to see migraine added to the census. We have most of the top 10 diseases that affect Australians, and migraine's in that top 10, and it's not there. So I think we've got a pretty good case for that. Recognizing that chronic migraine is a disability, and having that added to the list of disabilities that's recognized, we think is important, and we have a strong case for. We want to make sure that the treatments are fairly priced and accessible, and getting PBS listing for that is really important and part of that. We also represent the voice of migraine and headache patients in hearings, in consultations, in public testimony that has been given, which you can see in the far top right-hand corner of me doing so a little while ago. And attending appropriate events and making sure that migraine is represented and not just an afterthought in the plans and the policy that's happening by policymakers and legislators in Canberra. And just in addition to this, we have advocates that we've recently trained. There's been an advocacy briefing that we've had, where we briefed in another webinar a small group of people that put their hand up. And it's not too late to join this group. And we've got a toolkit that outlines step-by-step how you as an advocate can support us. And so if you're interested, make a note of that link below. Check out our advocacy briefing page. The webinar is there. It's free to view. And if you're interested, we'd love to hear from you. Okay, so let's get into the details for tonight. And we'll just make sure you're in the right place if you have migraine or headache, or if you're a partner or a caregiver or parent, if you'd like to connect with others like yourself, or if you want to ask a question. And if you do want to connect with others and you're not yet part of our support group, I know that not everyone is a fan of Facebook. At the moment, our Facebook support group is the best tool that we have, with 4,500 people who have migraine and headache disorders. And so if you want to bounce ideas off, this is something that might be a great fit for you, and a good way just to get another person's feedback. And I can see that many of you are already familiar with the reactions. I love to see those. Thank you for using them and to give feedback to myself and to the speaker. If you want to know how to use those, you can just use the symbols down below. The Q&A is there, the chat is there as well. But don't feel any pressure if you're not comfortable. You don't need to look at the chat, and you can close it and you can reopen it at a later time. It's absolutely fine. For those people that may have raised their hands, unfortunately, we're not going to have that function of unmuting other guests. If you do have a question, you may feel free to do that with the Q&A or posting your question in the chat. So introducing the people that you're going to be seeing tonight or hearing from is the first is Anik Grundy, who's our webinar moderator. She's been with us for 3 years. She does a lot of the reading, the content, I should say, the article development that you read, as well as our newsletters. She's also heavily involved in the Brain Foundation, our sister organization, and she's wonderful, and she's here in our moderator. And so say hi to her. She's very lovely. We also have myself. If this is your first night, I'm the Director of Operations at Migraine Headache Australia as part of the Brain Foundation. I've had migraine for a few decades, and I've struggled with chronic migraine myself. And today I try to support and advocate people living with migraine and speak out publicly at every opportunity I can across multiple forums, including Migraine Headache Australia, the Brain Foundation, Coalition of Headache and Migraine Patients, the Global Patient Advocacy Coalition, the World Health Education Foundation, and the International Headache Society. And there's more to be done. And that brings us to our expert tonight, Dr. Faraidoon Haghdoost. He is a medical doctor. He is a research fellow and a PhD. He is based at the George Institute for Global Health, University of New South Wales in Sydney, Australia. We're very fortunate to have him because he's one of the few researchers, the few talented researchers that is full-time in headache and migraine. And he sees the opportunity and the need to address research towards a cure. And he's very passionate about the science, engaging with healthcare providers. He's also fantastic on social media. You'll get to see he's got this fantastic logo with the big hair, and you'll get to know him as the big head pain guru and brand. So without further ado, let's hear from what Dr. Haghdoost has to say.
Hello, thanks for having me here. I'm very happy to have this presentation today. So a quick introduction about myself. I'm Faraidoon. I'm from Iran. I'm a general practitioner from Iran. I worked as a GP for about 5 years in my country. Then about 4 years ago, I came to Australia as a PhD student to study headache disorders. About a few months ago, I finished my PhD, and now I am a full-time headache researcher at the George Institute for Global Health, University of New South Wales in Sydney in Australia. This is, if you scan this QR code, you can visit my website, and you can, if you like, you can follow me on my different social media profiles. As I said, I'm from Iran. I'm from Kurdistan of Iran. My first language is Kurdish, and this is my city, a mountainous area, which I love that city. This is my Kurdish clothes. Kurdistan and Iran in general has 4 complete different seasons. You can see snow, jungles, very cold areas, very hot places. So traveling in Iran will give you a lot of different types of weather and nature if you go. These two are my parents. My mom, they are living in Kurdistan. About 3 years ago, my mom called me and said that she has a headache, a new headache that she never had it. And after talking about that, I honestly didn't know what's happening. I couldn't give her any diagnosis. But the most important thing was she told me that it is very new, and she never had such headache in the past. She had a headache like tension headache before, but she never had this type of headache. My mom, the time that she told me, she was about 65 years old. So before any diagnosis, the most important thing for me was, this is the red flag. And what is red flag? For some types of headache, we have to be careful. Maybe this headache is because of an important thing that we have to quickly make a diagnosis, or we have to solve that problem. So we have lots of different red flags that it's good to remember, especially for doctors that they visit people with headache. So like the case of my mom. So during the time, lots of research has been done in this area. And so a few years, several years ago, there was a mnemonic like Snoop, that they say that anyone that comes with a headache to your clinic and has these types of headache, you should be careful and check for important reasons. For example, for brain bleeding, for tumor, or for important things. So it's not like we should learn like what S, what N is like, or this is just something I like to talk about it and mention it. So one of them is when you have a new headache, or you have a headache which is with a systemic symptom like fever. So if you have a fever and you have headache, so it can be in most cases just a very simple thing like common cold, but we have to also be careful about maybe this is a sort of infection in the brain or something more serious that we have to be careful. Before going through all of these things, I should say that we have this mnemonic, we are learning this, but still many people that have these things, still their headache is not dangerous and it is still normal. But we have to be careful about the important causes. The other red flag for headache is if your headache is with some neurological symptoms. For example, you have a headache and you cannot move one of your arms, for example, or one part of your face. This is very important, and we have to be careful about important reasons or secondary reasons for that headache. If you have a headache, which is very new, it happened just, for example, you know exactly when it happened, and in a few seconds, it become like the worst thing in the world. That headache is very important, and we have to be careful about. If we have a headache in older ages, they usually say over 50 or over 45. So this one is my mom's case. She had a new headache at age of over 50 and she never experienced it. So it was very important for us and we had to check it. Or if you have a headache, like you had a headache always, but now it has changed, you feel that. You can say that this headache is not like the headache I always had. This is also important, and we have to go and talk with our doctors, or if you are a doctor, we have to be careful about that. More research were done, they developed it, and they added more, like it's now Snoop 10. We have 10P here. We don't need to memorize that. What I mean is we are trying, people like different researchers are trying to improve the knowledge that we have and add more things. But still, if you check this paper and also talk with your doctor, we have these red flags, we had this important information, but still it's not enough. Why? Because we say, okay, if you are over age of 50 and you have a new headache, you have to go for have a sort of imaging, MRI, CT scan, or anything. But still, over 80% of them, 90%, still after doing this imaging, it's normal. But that 10% is very important and we have to be careful about. The thing is, clearly, we need a better way to screen for this. Maybe in future we can find other ways. So that's why, for sure, we need more research in this area. So I just like to summarize what I said about the red flags. So if you have a headache that has a symptom like systematic symptom like fever, it's important. If you have a headache that part of your body, or like you have a part of your body is like numb, or you cannot move it, or you have a neurological symptom with that, that's important. If you have a headache in older ages, which is new headache, it's very important. If the pattern of your headache is changing, if your headache is very sudden and is increasing suddenly to the highest level, if you have a new headache, especially new headache during pregnancy, these things are very important and we have to be careful. But it doesn't mean that if you have these things, it is always bad. Mostly everything is normal, but we have to just be careful. So that's what we did for my mom. We sent her for imaging. Everything was normal. And after a few months, actually I can say after 1.5, 2 months, everything was gone. She was normal, no headache, and it was done. So I could never tell, I didn't know what happened. I just told her that it's good that everything is normal, it is gone, I don't know. So how we make diagnosis, and when I said I didn't know what's happening, it was based on this tool that we have. For migraine, for headache disorders in general, it's not like a disease like diabetes that we can do a blood test and say, okay, your blood sugar is over this, so this amount, and then you have diabetes, for example. For migraine and other headache disorders, unfortunately, we don't have at the moment any test like that. So what we do is we use history taking and also this tool that we have, that for each disorder, we have this specific criteria. if your headache is fulfilling these different types of characteristics that we have, we say, okay, probably you have migraine or you have other disorders. So for my mom, I didn't know. She didn't fulfill any of these headaches, and I didn't know what's happening. For example, for migraine with aura, we have this criteria. I'm not gonna go through it, but this is a very common criteria now. Fortunately, all over the world, people are using it. I just like to say one point here. For example, in section C here, we say that it is migraine if that person, that headache has two of these four characteristics. It should be one-sided or pulsatile or moderate to severe pain, or be gets more serious with physical activity. So this is something that I just like to mention, that sometimes even in doctors or some people like that we see around us, they say that if your headache is in both sides of your head, then it is not migraine. But it can be. Why? Because your headache can be in both sides, but still be pulsatile and the severity be moderate to severe. So you have two of these four, you don't need the other one. Or for example, your headache might be not severe, not even moderate. You can have a mild headache, but your problem, for example, be other things like nausea, vomiting. But some people might say that, okay, your headache is not that severe, so it's not migraine, but still it can be one-sided and also pulsatile, but mild, but still it fulfills this criteria. So this criteria, clearly it will be better and better in the future, but this is the way we diagnose migraine and other headache disorders using this criteria. And the criteria is made by International Headache Society, which is called ICHD, International Classification of Headache Disorders. About a few months after my mom had the headache, I read a paper which was very interesting. It was a group of colleagues from China that said that they introduced a new headache, and they said we want to add a new headache to the International Classification of Headache Disorders, to that tool that International Headache Society has for diagnosing different headache disorders. They said we want to add a new headache to that, and the headache is headache after coronary intervention. Coronary is like these vessels around heart that sometimes, because they are blocked or there are some issues there, we do some interventions, or we go for just imaging. What we do is they have a contrast, or like they inject a dye or something there, and then they do imaging to see if these vessels around heart are blocked or there is any issue. And if there is an issue, they can go and open it. So they said that during coronary intervention, for example, just simply imaging, which is called angiography, some people get headache, and they said about 25% of people after this intervention, they get headache, and the headache has these characteristics. And when I checked that, I realized that my mom had that, which I didn't think that this is the reason. That time I thought about it, but I said, I don't know, probably it's because of that, but we are not sure. But this is a new headache that is not in ICHD 3, which is the third version of the classification. And it was very interesting for me. Just to quickly say how I've read this paper, like for me, I have a routine. Every night I use this app called Read, that in this app, you can check, follow some specific journals on or some specific keywords. For me, I follow these important journals for headache disorders, which is one of them is Cephalgia, Headache, Journal of Headache and Pain, Current Pain and Headache Reports. I follow these headache journals. And also I have some keywords. By keyword, I mean, if there is any paper in the world that has the word headache, for example, the word headache and Australia, I get a notification that the paper is published with the word headache and Australia, both of them. Then I check the title. Maybe it's not at all related to headache disorders, but maybe it is. Then I check the abstract, and then I will read the full text if it's related. So this is how I try to stay up to date about my field and my research. So this paper that I told you reported a new criteria, and they said if someone has this, we can say that it is the headache related to coronary intervention. which was very interesting for me, and it was exactly what my mom had. So we have another types of angiography headache in ICHD 3, but it is for when you do the angiography for the vessels in the brain and neck and not heart. So as it was very interesting for me, we decided to do the same study, because usually one paper is not enough to add it to that criteria. So with the help of 2 cardiologists, 2 neurologists, 4 medical students in Iran, we designed a study and we tried to repeat exactly what our colleagues in China did to check if after this intervention or doing angiography for heart vessels, if after that there is headache, and if there is, what is the percentage? Is it like them 25% in Iran, or it's different? And if it's like that, what are the characteristics? Is it the same? So if we can repeat the same thing, find this relevant data so that we can combine these 2 papers, and with a stronger evidence, we suggested to International Headache Society to add a new headache, for example. So far, about 300 people that came to that center to do the angiography for their heart accepted to join the study. Their data is collected, and we haven't done the analysis yet. But with the help of them, we may be able to really add a new headache. And just by doing that, it will be, if we knew something that it is gonna be a disorder like that, so we might wait longer to do the imaging for my mom. So less imaging. My mom was very worried. So her headache was not severe. It was not bothering her. The problem was she was scared, because she said, what's happening to me? Why I never had this headache? What's this headache? And she was really scared. So if I knew such thing, I could tell her that don't worry, probably it is this. We might need to do imaging, but still it's probably this disorder. And she would be feeling less stressed, which at that point it didn't happen. So hopefully we can add to evidence by just adding a new disease to the classification. This is Rigmor, which is one of my role models. She is in a Danish headache center in Copenhagen. And this was a presentation she had. She said, we have three most important eras for headache research. The first one was 1988, which was the classification. So in 1988, this classification, this criteria that we have to diagnose different headache disorders was made. And it's interesting that that year is the year that I was born. And after 35 years, around 35 years, now I am gonna help with a group in Iran, and to add another thing to this, or to be helpful for the new update that it will come. So this is research. This is like someone starts something, and during time, many people come and help and make it better and better and better. So I will be happy if actually we can have a contribution in the new update. So this is me when I was graduated from medical school. For always, I was interested in gaps in knowledge. But I was very naive, and I thought that we know a lot. When you don't know anything, you think you know a lot. And gradually I learned that, this gap is big. And now I know that this is bigger. And I think one day, and the thing is, this gap is that big that actually not just for headache disorders, I think we know nothing about anything, and we are trying to learn still, the whole knowledge in the world. But the more you learn, the more you know that, oh my God, this is not good yet. It can be better. For example, also the knowledge that we have, we are not using it properly sometimes. For example, people with migraine, we have this tool from 1988, but still over 50% of people with migraine, they never get a diagnosis. For different reasons, they don't get diagnosis as a migraine. And that's a huge thing. For example, a disease like cluster headache, which is a very severe form of headache. It is different from migraine, and it's not as common as migraine, but it's a very severe form of headache. People with cluster headache, it takes them about on average 7 years, 6 years to get diagnosis. Like they go to different doctors, no one knows what's happening. They receive medication, they say this is migraine, this is that problem. And after 7, 8 years, 6 years, they get a diagnosis. So, and we have the criteria, we have the diagnostic tool, but we still don't use it or still don't use it properly. So we need more, we need to learn more a lot. The second era that Rigmor mentioned was triptans. 1990 was the year that, like, the time that triptans were available, like sumatriptan, the medications, you might have heard about it. So why triptans are this important? I'm gonna just go through migraine management, what's happening, and then we'll talk about triptans. So for migraine management, we have non-drug methods and drug methods, like using medications for migraine. For non-medications or non-pharmacological methods, I have a review paper that collected all available information in that paper. Just to summarize is, like, if we can, we should know and learn about migraine more, and also know and learn about triggers. And if we can, we should try to avoid them or learn how to live with them. Sometimes we cannot avoid a trigger, like, for example, menstruation, or like we have to do something, or like stress that's still difficult to manage or avoid. So we have to try, for example, not to put triggers together. Like during menstruation, it's better if we go to beach, we make sure we have sunglasses to get less light. For example, these are just like examples. But it's part of the learning about the disease. Some food causes triggers headache in people with migraine, but not every food, like for everyone. So for example, wine, chocolate, these things can trigger, but it might not trigger in your case. So it's good to know what food you can have, what food is better to have less, or like at least not have it when you have other triggers. So if we can, we should have regular sleep, but it's easy to say that have regular sleep and like then, but sometimes you cannot. You have night shifts, you have different things, you cannot sleep well. And we should be careful not to make it another stress for us to say that, okay, I have a migraine attack. Maybe it was my fault because I didn't sleep last night. So it was not your fault, it happened. But this is the thing that we should know. Or some people blame it on other people that, for example, if you have a headache, someone else said that I told you not to do this yesterday, that's why you have headache. But that's wrong. We need this information that to learn, just to learn more about it, and if we can manage it better. Physical activity, reducing weight, these things are helpful for some people to have less headache. So these are part of the non-pharmacological migraine management. Or there are some devices that will help, like neurostimulation devices, for example, gamma core cephalate that you see in this picture. I'm not going to go through them. The last one, transcranial direct current stimulation, we are doing a review to check, to collect all the available studies that we have for that, and then put them together and see if it has effect or not. So that's another sort of research that I'm interested in, to collect available data and see, make a final decision, or make a decision that, okay, based on available knowledge, it looks like this device works, or if we need more paper studies, or if like it doesn't help, or things like that. For migraine management, we have a pharmacological part, which has two parts, acute and prevention. So acute treatment is when you have headache or you have the attack, at that time, you take medication to stop the attack or to reduce the impact of it or reduce the severity. But for prevention is, you don't have any attack at the moment today, but on a regular basis, like daily, you take a medication to make sure you don't have more headaches in the future. Where some people, they don't need that because their headaches are not that much, or like it's manageable, so they just go with the acute treatment. But sometimes it's necessary and you have to go for prevention. So for acute management, we have two different types of medications. One group is non-specific and the other one is specific. Non-specific, we mean the medication was available, it's not for migraine, but we use it for our headaches or for our attacks. For example, paracetamol, ibuprofen, aspirin. So we have different medications that is like already available for other things, painkillers. So we also use them for our headache, for our attacks. But we have a group of acute management, which is specific. This is where triptans come. So triptans, 1990, were the first medications, like group of medications that were specifically made for migraine management, for acute migraine management. Also, if you look at this figure, after about 30 years, we had a new group of medication, which I think you have heard about it. It's called anti-CGRP medications, calcitonin gene-related peptide. So these medications are for prevention. If we go, just to quickly tell you about the triptans, like we have lots of different triptans. If one of them doesn't work, the other might work. Still lots of research are being doing, like why some people, this one works and not the other one. But this is something that you can discuss with your doctor if you want. About the prevention, again, we have non-specific and specific medications. So for many years, as I said, it was about 2018 that CGRP medications, anti-CGRP medications were available and made. For prevention, we had non-specific medications for a long time. And what are non-specific ones? They were designed for other disorders, but for some reasons, by chance or by some studies that happened, we realized that they are also helpful for migraine. For example, blood pressure medications. We did a review on blood pressure medications, and we checked that we collected all available studies, and we found that they are helpful. But not every medication works for everyone, and the amount of a reduction in number of headaches in a month can be like for example, you can have 10 days with headache in a month. After these, you still have 5 days, 6 days. So it's not going to make it 0. But still, the good point about some of these non-specific migraine managements they are available in many countries because many countries, they, for example, manage blood pressure, high blood pressure. So blood pressure medications are available there. But we have specific migraine medications for prevention, which CGRPs are one of them, anti-CGRP medications. And they have shown a very good effect, few side effects. And for some people that nothing has helped, it has helped them. And still lots of research are being done, in many countries, they will be reported. And it's a very promising treatment. And all of these things, all of this research on headache and migraine, especially migraine, is for a disease that is very, very common and very severe. It's like the first cause of disability in young women, and the second in all people. 1 in every 4 families has one member that has migraine disease, if we look at it globally. 1 in every 7 people has migraine, and 3 in every 4 people with migraine is female. We can say in the world we have 1 billion people. And you see that with all of these things, these huge numbers, this huge impact, we still, we could be faster. We could do more research. But fortunately, I see these days, we have lots of headache researchers in different countries. Things is changing, and we have to thank those people who started 35, 40 years ago, doing research, fighting for it, and then increasing awareness among politicians, among researchers, among people. Now we are in the stage that more research is being done every day, but still clearly we need a lot. As I said, the gap is always big, and on headache disorders is very important. And just imagine for a disease like migraine, that is this common, we have this many problems and gaps. How about other disorders like, for example, cluster headache, that we don't have, it's not that common. It is very severe, but it's not this common like migraine. So how can we find money to do research on it? How can we convince people who fund research? Lots of other things that we still need to work on them. After CGRP, still, it's not like we said, like researchers said, it's over and there is nothing else. We we finished migraine treatment. Now it's like clearly we still need more. So new proteins are being studied, like PACAP, that these days it's being studied, and it's like blocking these or might be another future medication, like to block PACAP, and then who knows, maybe this one is even better, or also maybe in a few years more molecules will come. But still, these two, CGRP and PACAP, are like the ones that looks very promising, and hopefully we will have studies on new molecules, trials on new molecules, and we'll see more effect. So this photo of me that you see here, it is me exactly in Danish Headache Center. And for me, I don't do molecule studies. I don't do animal studies. So they have lots of different settings there. So I was there for a month and I learned a lot from them. And I was very curious, like, about their research. They are doing amazing research on headache disorders. But what I am interested in is mostly, as I said before, review articles to collect available data, put them together, and report a final decision or final data about what is available. But the other thing that I'm interested in is called clinical trials. This is what I like to do in Australia. So clinical trials, we have a volunteer, someone that wants to join the study. We give that person an intervention, and then we see the effect of that intervention. For example, in the case of my mom, it was not clinical trial because we didn't add the angiography to those people that decided to participate. They already had it. They wanted to have that for another reason. What we did, we just collected data before and after they do that, but we didn't add angiography. But for clinical trials, for example, we say that we have this medication. If you're a volunteer, you can take this medication. Then we follow you for about 3 months, 2 months, and we see if it has effect or not. Sometimes for clinical trials, you need to have another group because, for example, if you say, okay, let's see if paracetamol has effect, maybe it is just because of, we call it placebo effect, for example. Placebo means any medication you take, you might feel like it has effect. Or maybe even if you don't take any medication, after a few weeks, it is gone by itself. How do you know that it was because of the medication we gave you? So it's better to have two groups, and each group get a different intervention, like paracetamol against, for example, ibuprofen. Then we see after a month which one has less headache or less symptoms for that kind of disorder. I'm very interested in designing some trials in Australia with the help of my team and other headache researchers in different cities in Australia. One of them is, it will be great if we do more studies on anti-CGRP medications and compare them to another medication or compare them with placebo, which is like, as I said, it's like a medication that actually doesn't have the active thing. So it has no effect, actually, no active component in it. But we should be careful to compare any medication with another thing in another group to make sure that we are evaluating the exact effect of the active part. For example, here, anti-CGRP. Another thing is we like to have studies to combine different medications. For example, when people get anti-CGRP medications, not everyone will be zero headache. Some of them, they still have some headaches at the end. So what if we add blood pressure medications to that? Is it like we can reduce it more? Or also, sometimes CGRP medications might have we still don't know if it increases the blood pressure or not, or if it has like some side effects. So what if we add it to a blood pressure medication which reduces the blood pressure? So this is another study. But the one that these days I'm very keen to do and try to get grants for is to check the effect of psilocybin, which is the magic mushroom, and the disease that we talked about, it's named cluster headache. Cluster headache is very severe. Unfortunately, the available medications that we have is not that many. We don't have that many options. And also they might not work for some people. and we don't know what to do after that. So we really need more studies on that disease. And it looks like psilocybin can be a candidate for management of cluster headache, but we cannot say that before any study. There are some very small studies available. There are people talking about it in the blogs, but studies are very small, and we need a big and controlled study. So this is something that I'm very interested in doing in the future. And we were thinking before doing that, we should have a survey and ask people with cluster headache. We will do the same thing later for migraine also, that if we are going to do research in Australia, what do you think we should do? Do you think, maybe we think psilocybin is important, but people with cluster headache believe that there are more other things that should be studied that are more urgent, for example. We just like to see if people are keen to join these type of studies, if they have other ideas, if we do this and if they like to join, if they have any ideas in how to design it, if they are happy with coming to the center, is it possible for them? Lots of other questions that we like to know more about it. So we will design a survey, online survey very soon after getting ethics approval from university to ask people with cluster headache about their ideas. And also if we can, we would like to invite some volunteers to our center or like online talk to just talk more about the design that we like or what they think we should do. So for every research, we need a lot of things. We need money, we need a good infrastructure and setting in our center, we need ideas, we need a team, and the most important one is we need volunteers and people to help us to do that study. For example, the study that we are doing in Iran for checking the effect of that angiography for heart vessels and the headache after that. So there is no way to check that if no one is going to be volunteered to join the study. And after that, by their help, you can add something to the knowledge, and then it will be used in many other countries, many other people that they go for imaging or for any intervention. When they have headache, you say that, okay, like this is might be because of this, and you reduce the number of imaging in the world, you reduce the number of like the amount of stress that people might get because of these headaches. And this is something that will help everyone in the world. So as I said, there are lots of research about headache disorders currently in the world. Many researchers we have. In September 14th to 17th in South Korea, in Seoul, there is a congress, which is conference, which is the biggest headache conference, I believe. And thousands of people might come there. So I will be there. I have a presentation, but I also will be there to meet many people and improve my connections and learn more about them. And I will try to post about it on my social media accounts. Thanks, everyone. I'm Faraidoon, but if you cannot remember my name, remember my big head and my field of study, that is head pain. Thank you so much.
Thank you, Dr. Haghdoost. That was a fantastic presentation. Covered a lot of ground, and we've got a lot of questions. So if you've put your question in, fantastic. We've been keeping track of those. If you haven't yet, please feel free to do so. And we'll jump off first with a question from Anna, who asked if anyone can access the journals that you had mentioned, like the open access journals.
Yeah, thanks. Thanks everyone for attending and for your interest in the talk. I hope you enjoyed it. Before I answer that question, my way of presenting is usually different from other people. So I appreciate your feedbacks if you like this sort of presentations. And yeah, I really appreciate it. So about the journals, some of them, like a journal like Cephalologia, recently became open access. So now everyone can access to the paper. So you just need to go to the page, to their website, and even if you don't have access to any library, any university, they are available. I know that Journal of Headache and Pain is also available. So yeah, they're and most of the journals these days are going to be open access. So I think in the future, more papers are available for everyone if you like.
Fantastic. That's good news. Jen asked, what is an angiograph, or what is angiography? And is this something that patients could ask for?
Sorry if I use this sort of like terms. So angiography is to check the vessels. In order to check the vessels, you go inject a color in the vessel, and then out like from the outside of the body, you can do imaging with. You can see this color in the vessel. Then you can see if it is open or closed. So we can do it for like lots of different disorders. For example, for the heart, what I said, you check if the vessels around heart are open or not. So no, for migraine, we don't do this for migraine, but for example, in this case, sometimes we do it to check the secondary causes, not about the heart, but sometimes you check the vessels in the brain to see if there is any issue, if they are blocked, if there is any issue there. So it's to check if this headache is because of another thing. So we don't do that for a headache, for all headache. We don't do that to diagnose migraine. So migraine has a different way to diagnose. So no, we don't need that for migraine, but we do that for other reasons.
Right. So we had a question from Samar who asked about how we can participate or be notified of clinical trials that are happening. I know that on Migraine Headache Australia, we have a page called Participate in Research, which you can find in our menu under the Support Us and Participate in Research. And so when organizations like research institutes approach us, then we can post here sort of different research studies. So this is a link that you can use. If you're not subscribed to Migraine and Headache Australia, how else can people find out, Dr. Haghdoost?
Yeah, that's a good point. Actually, that page that you have, I sometimes check it just to see what's happening new in Australia or like new research that you are looking for participants. But that's a little bit difficult. Finding participants, like connecting participants with researchers everywhere is a big issue. Like sometimes people are keen to join, but they don't know if there is a study. So for example, the Georgian Institute, what they are doing, they have started a new initiative. They call it Join Us. So people go register there, and then they select if they have a like disease at the moment or not. And then when there is a trial, this program is the plan is to be a big registry. Then if there is a trial, they email the people and they say we have a trial. Or even if another university has a trial, it's not just like for Georgian Institute, they can send email to everyone. So if you are, for example, interested in this case in headache, so for example, you can follow researchers like me or other researchers in your area or in Australia that you think that if, for example, if there is a research in UNSW, if you like to join, so it's good to follow people in this area if you have, if you use social media. If not, you can just one time register in one of these new things that we have. I don't know, Carl, if you have such thing, but like join us for the Georgian Institute, you can register there and they will email you if there is any study. Another thing that I think we are planning to do is if we have a trial, we are planning to ask GPs in different areas just to put like flyers or like the advertisement there. But still, it's very difficult. I understand that.
Yeah, I mean, we update our page, but if people don't approach us and like we're not proactively looking out for research trials, it's really if when people approach us. So we do get a lot, but we don't get all of them, that's for sure. One of the things that you spoke about earlier on in the presentation was red flags. And Jane had a question about migraine and was concerned about brain damage that may arise from migraine, particularly migraine with aura and hemiplegic migraines. Can you speak to whether there is brain damage occurring during these migraine attacks?
The red flags that I talked about is about other reasons that are not migraine. So, for example, you have a very new headache, sudden headache. It might be, I don't know, like vessel rupture in like brain, for example, which when we say it is red flag, we are worried about the other reasons which are not migraine or tension headache. And if we check those red flags, we find that there is no issue, then we go for other disorders which are like migraine. Then when we say it is migraine, then we are somehow relieved that it is not a serious, severe thing that can kill you, for example, or like can make it permanent damage that is like we cannot, we have to prevent it. But migraine, there are studies that it can have some minor changes in the brain tissue, which we are planning to do a review and check how the changes. But no, I don't think based on the current evidence, migraine is gonna cause damage to the brain, but it has some impacts on the function of some parts of the brain. It can have impact on some dots and small white dots on the brain, which we don't know if it's really because of migraine or it's just other reasons. But no, I don't think we can say that migraine is gonna cause damage to the brain.
Mary had a question about migraine and COVID, and said that her neurologist had said that some people had developed migraine after getting the vaccine. I know this is an emerging area, and it's an area that needs more research. What do you know about sort of COVID and its relationship with migraine, and either making migraine worse or starting it, or causing migraine?
Yeah, I can say about headache, COVID. Well, one of the main symptoms was headache, and it was interesting that they found that people that one of the symptoms was headache after COVID. People who got COVID and one of the symptoms was headache, they were less likely to go to hospital or be in ICU or be in a very critical condition. So it looks like those who had headache had a better future compared to those people with COVID who didn't have headache. These are some studies that was very interesting during COVID came out. And about migraine, it's like flu or common cold that it can be triggered. You have migraine, or migraine was very minor, not with many symptoms, and suddenly you got this disease and then it became severe. Yeah, I'm not sure about how many studies we have that said new migraine exactly after COVID, but my colleagues have contacted me. I don't visit patients. I'm not a neurologist, but my colleagues have contacted me that new people they were diagnosed for the first time. At the beginning, they said it was a migraine after COVID, but headache after COVID, but then gradually they realized that all the symptoms goes well with migraine, so they diagnosed them as migraine. Yeah, so it can happen, but I'm not aware of any review or report. I can search, maybe share with you, and you can share with people.
We had another question about other types of headache, which can be totally debilitating. Why are they given such low priority compared to migraine?
To be honest, even migraine, we don't have that much funding and research on it. I believe that something like migraine is common. We had to solve these things many years ago, because it's super common, super severe. But that's the issue. In Australia, for example, every grant that we apply, the chance of getting the money is 5%. We have to apply 20 grants to get one. So they don't have that much money, so they give it to just a limited number of people. And then we have to have a very strong argue to say that this is the reason it is important. Yeah, it's not very common, but it's very severe. And it's we need to solve it. So now in Australia, there are some grant opportunities, they call it rare diseases. So they try to bring some money to these sort of disorders that separate them from other disorders which have less chance. So hopefully, with the help of these focus groups that I said, we can make a strong proposal, strong grant, and then do more studies. But yeah, unfortunately, when it's a rare disease, and there is another issue here. When there is a disease is rare, sometimes it's difficult to study, or because you cannot find enough participants. For example, cluster headache. Many groups wanted to study it, for example, psilocybin and cluster headache, but they all stopped with just 10 participants. They stopped this trial because they couldn't get enough participants for lots of different reasons. People were not aware. People we didn't communicate well, or they were not close to university. The psilocybin, you should come to the center. So if someone is in a rural area, then it's so difficult for them to come every week 2-3 times. So there are lots of, and finding enough participants in Sydney that are keen to join the study, close to for example, Prince of Wales Hospital, is very difficult. So that reduces the chance. So, but that's why we have to communicate better, and all of us together, for example, in Australia, talk about is how we can solve this issue. Then we can get grants also, hopefully.
You mentioned the International Classification of Headache Disorders, ICHD. What's the purpose of distinguishing between primary migraine and secondary migraine? Patrick had that question in terms of research and treatment.
I can say that, we have two types of headache in general. One headache is a headache that we call it secondary headache, which means that the reason for that headache is something else, and the headache is a symptom. So if we solve that something, then the issue is gone, is solved. When we say primary headache, like the disease, the nature of the disease is primary headache, which means that it causes headache, like migraine, like cluster headache. So, for example, that headache for my mom that I said after like coronary, like heart vessel angiography. So if we know that, then we don't think about migraine, because we say that it is because of this. Then after 2 months, 3 months, usually it will be over and then it is done. Or maybe it's because of something severe, like for example, for my mom, she was really worried about brain tumor, for example. So we have to find the secondary causes of this headache and then distinguish them from each other. Then we don't miss like treating critical things that we have to treat today. And then if it's migraine, then we know that we have to have a long-term plan for management of it.
Are you able to comment on the background and the current status of ditans? The question came from Paul.
Yeah. There are new types of medications for, like, as I said, we have acute management when you have the attack and preventive when you don't have, but you want to prevent future ones. So like ditans, like lasmiditans is about acute treatment. And I know, for example, in Iran, sorry about this, light is automatic. I know in Iran, people don't have access to that, but it's available in many countries. And the background, actually, I don't know like how it started, how they found like to study that. But some people that triptans don't work, they can switch to ditans. Like they can try different triptans, and if doesn't work, they can go to ditans, and they have like different side effects, different functions, and it can help for them. Yeah, but yeah.
Maureen had a question about the current research into CGRPs. She said that it's so new, but the online feedback seems to be so negative with side effects. It makes me hesitate to try them. What have you seen in the research about the CGRPs?
That's a very good question. Yeah, they are new. Yeah, and some people are worried about what if. Yeah, you have studied it. That's the question that people ask. You have studied it. You said there is no side effect, but what if the side effect is long term, not tomorrow or not these 6 months? What if it happens in the long term? So we have, for example, review that I think it was on erenumab, which they followed people for 5 years because like they had time, and they have followed those people on this medication, and they didn't find any severe side effect. But still, the reason that we believe they are good is they are helping some people that nothing helped, and they are reducing, like in some people that's like like a miracle. It moves it from 20 headaches a month, 20 days with headache in a month, to 5, 3, to 0 in some people, and nothing else helped those people. But for some other people it doesn't help, or they have to switch to another one because of different reasons. Sometimes it's just the side effect that they have. Some people complain about constipation. Some people have, like, they say it's like it causes hair loss. But there are lots of studies. They have found that in general, they are very safe. Long term, we have 5-year study that they don't have that many side effects, like long-term side effects. And it looks promising. But yes, still there are lots of studies, still more clinical trials should be done on this. And hopefully we can do more, like even in Australia.
Fantastic. Dr. Haghdoost, it's been so great to have you on. Thank you for sharing some of your work with us. Thank you for doing, on behalf of the migraine and headache community, thank you for all the research and work and your passion. We're all very grateful, and especially for tonight. Thank you very much.
Thanks. Thank you so much. Thanks everyone for joining.
Tomorrow, we have 2 sessions running, one at 11 o'clock on concussion with our ex-NRL football star, Brett Carney. He's going to be interviewing Australia's leading concussion expert, Dr. Rowena Mobbs. Don't miss that at 11 a.m. tomorrow. That's in the morning. And then we'll have a session tomorrow night about migraine at work with a panel of patients and also a solicitor that's an expert in discrimination. So we look forward to seeing you there. But for now, good night and thank you.